There we go. Nice. I have unrelated disclosure. I was a consultant on another AI unrelated project with Image Biopsy Lab about a year and a half ago. So I'll discuss current state of AI in vertebral fracture detection, and if I don't run out of time, I will give you some philosophical points about how to deal with all this FDA approved and FDA cleared business. Just a brief couple of points. Obviously, in young patients, trauma, sports, traffic-related accidents result in vertebral fractures, as opposed to older patients where we're dealing with low-velocity trauma. And a lot of times in older patients, those fractures are occult. Depending on how studies set up, imaging studies will show anywhere from 1/6 to about 1/3 of positive fractures on X-rays and CTs. I was in a similar situation a couple years ago where I was doing an AI talk after lunch and everybody was quite asleep. So I asked my neuroradiology colleagues who were doing some AI at that point, I said, do you have any cases that will wake people up? And they said, here's one that this will wake people up. So this was a trauma case in a young patient. Clearly there's a C2 fracture. And you can see here that AI software also detected a posterior fracture in the spinous process of C6. If I zoom in here, there is a little line that if you squint, you will see there's a little arrow there. There is a lucency going through the spinous process, and that's what AI software was trained to pick up. Interestingly, nobody is doing any denoising on CT images, so if you look carefully here, there's that usual artifact as you go down into the lower C-spine. Becomes quite noisy there, and then if you keep on looking, is it real, not real? So here's the study 3 days later, analyzed by the same software. After upper C-spine was fixed, now software is not picking anything up in that spinous process at all. So what's going on? It didn't heal in 3 days, right? If we zoom in, is that line real? Maybe, but there's a lot of artifact over there. When we look on axial images, I really don't see anything to call there as a fracture. And on the coronal images going through that same area, there's really nothing there as well. So back then, comments were that this works very well when, especially if I don't have to open any other software as part of my PACS system, and people were using it. At a different site, we did not have it integrated in the PACS system, so nobody was using it very much. And people also noticed that once in a while, the software overcalled vertebral artery variations as fractures. Fast forward to now, we now have a little gadget that's popping up on our screens that says there is a positive AI finding. It's much better that we have it all in front of us rather than opening a different software. But unfortunately, everything is still together. Head bleeds, PEs, malpositioned ET tubes, C-spine fractures, they're all kind of in this one list over there. This came on my screen just about 2 weeks ago. It seems like every couple weeks we get new gadget that shows us stuff in a whole different series, and the series keeps on growing and growing and growing. I'm still scratching my head as far as what exactly this is trying to show me, because unfortunately I missed the in-service when this was explained. But it looks like a little Christmas tree here. So now, there are some 15s here. I thought that 15 being red, that's probably a bad thing. But then I found some 15s that are green. So I'll get back to that in a second. Okay, going back into a little history, just 14 years ago is when all this started in the literature, it seems to me, where people start talking about, can we use computers to detect fractures to help us out in all kinds of studies? And the first study back from 2010 that I can find is really looking at gray levels. There's not much AI here at all. They're just kind of looking at gray levels and trying to come up with clever algorithms to semi-segment, semi-automatically, and then come up and say, okay, there's a high likelihood that there is a anterior wedge compression fracture there or not. Slightly forward 2 years after that, in 2012, people got a little bit more sophisticated, and now on CT scans, they're trying to unwrap each slice into black and white levels and kind of filter it out. Again, not much of AI over here. It's just algorithm that tries to figure out which line corresponds to a fracture, and the accuracy here, well, it's an area under the curve here, it gets into the 80s or so. So now we're obviously interested in what's going on now, and here we are, this is from 2024. How are we doing with radiographs? I think we're doing pretty good. This study here shows you segmentation of each level and then detection at either compression fracture or burst fracture. It's doing pretty good with burst fractures, not so well with compression fractures, and it's pretty good at deciding whether something is normal or not. The same paper made my job much easier because it summarized what's out there in the literature. They kind of went and said, what was there published before 2022? You can see sensitivity, specificities, and accuracies here. You'll see most of them are in the 80s, 90s, some in the 70s. And they said, well, that was great, but what about after 2022? And once again, it of course got a little bit better. All kinds of studies out there looking at various networks, and that accuracy, specificity, and sensitivity keeps on going up. Back to this particular paper, I'm actually pretty impressed because maroon color is what humans did, green color is what machine did, and then the last image here is machine overimposed on the human. It's pretty close as far as segmenting that vertebral body. On CT scan, the numbers are fairly similar. You will see some here that are in high 80s, some are in 90s, depending on what kind of algorithm, what kind of set of algorithms and approaches are used. All this on the science part, and some people are actually going quite detailed into all this. They're trying to classify, is this a superior vertebral end plate fracture or superior and inferior? And then they have all the way into the superior and all four lines of a rectangle. People go as far as trying to decide, is fracture stable or unstable based on how many columns of the vertebral body involved. Here we're not quite there yet. We're in the 70s or 80s, but it's getting there. Of course, once those algorithms became available and start getting installed, people start evaluating them on their own clinical data sets. And you can see that software is doing pretty decently compared to attending radiologists that had slightly lower sensitivity and higher miss rate of fractures. But there were some fractures that were missed by the artificial intelligence software that were not picked up, that was picked up by AI that were not picked up by humans. So conclusion here is, in cooperation, AI and human is actually squeezing out a little bit extra of sensitivity there. Another one that's similar, you can compare here neural network to radiologist accuracy, neural network at 92%, radiologist at 95%, and conclusions here are fairly similar. This particular study also, this next study also documented that, like we said many times here, that in some cases, it's faster to make the diagnosis when you have AI helping you. So back to what I have in front of me now. We have MIMPS type software that measures vertebral body heights anteriorly and posteriorly and decides to outline whether something is significant or not. Well, how is it doing? This is a real case, and it's doing okay, not exactly at every level. You see it only counted 11 vertebrae because it counted this 2 here as T6. And it seems to be comparing either above and below to vertebral body in the middle or posterior vertebral body to the anterior vertebral body, which begs a question of what should we be doing? Well, it seems that majority of people looking at this, they go with this theory that vertebral compression fracture is something different between 2 levels. So if you take a level above, level below, average it out, compare it to the level in question, that's how we're going to decide whether it's compressed or not. There was a working group a few years ago that kind of looked at all this from trauma perspective, and they acknowledged that, that's what most people do, but at the same time they said, we don't really have much literature yet, but we think it's maybe better to compare anterior border of vertebral body to the posterior border and decide that something is compressed that way. Well, many times during the day as I'm looking at the x-rays and as the day goes on, I see this a little bit of anterior wedge and I just really don't want to call it a fracture. So what's normal? We've seen those kind of wedge deformities, but it makes no sense whatsoever for them to be a fracture, especially in younger people. So somebody did very clever study on thousands and thousands of images coming from National Health Assessment Survey that goes back all the way to 1960s. This was funded a long time ago by federal government. People have a bunch of radiographs from those studies, and so now people can analyze them. Well, this is quite interesting because doing software, what these people did, they just went ahead and segmented it and measured anterior vertebral body, posterior vertebral body, and came up with a vertebral body height ratio. You can see here that depending on the level, about 10% plus or minus of how different anterior can be comparing to the posterior. Now you say, well, how did they know which ones were fractured or not? Well, they're dealing with thousands and thousands of images over here. So what they did is, for their analysis, they threw out everything that was above or below 2 standard deviations. So, having huge numbers, I think that's a decent study. All right, I'm going to start philosophizing here a little bit because I do have time. This study points out that we have to be careful when we say things like, based on evidence base, we should tell this patient to do X, Y, or Z, or this patient has or does not have a fracture. Way before medical school, as I was taking biostatistics course in undergrad, it was explained to me that if the sampling is fairly random, a lot of things follow normal distribution in healthcare, in biology, in medicine. So therefore, if you're covering 95% of the data, which is plus minus 2 standard deviations, you're only throwing out about 2.5% on each end. Interesting what happened in this 17,000 patient study. If you look at negative 2 standard deviations and positive 2 standard deviations, you actually don't have very many numbers that are close to 2.5% here at all. Quite a few of them are in the 90 range. So, when we're looking next time at an AI-produced fracture label and it says, there is a 99% chance that there is a fracture here, I do have a little bit of skepticism. Yeah, in that sample on that particular population that the study was trained on, that's what the sensitivity was. But for this particular patient, I think it's still up to you and me to decide, do they or do they not have the fracture? So if you are shopping around for for vertebral fracture detection software, I think the best place to go is to ACR, which back in 2021 looked like this and was a little bit cumbersome to deal with, but it got recently upgraded and now it's much easier to search through. Back to this case. So, what should I do? This is an FDA-cleared algorithm that was purchased by my hospital, and now it highlights this finding over here. I have choices. Before I tell you what I think we should do, let me clarify a couple points about what it means to be FDA approved or cleared. There are various classes of devices that FDA evaluates. Something as simple as a glove just gets registered and listed. Nobody really checks it to say, is it safe or not? Something as complex as a pacemaker gets approved after extensive safety process. Most of AI software, if it goes through the FDA process, will fall under class 2 risk, which is basically cleared. And all it says usually is that we looked at it, we compared it to what else is out there, and go ahead and market it for whatever you're saying you're marketing it for, we're letting you market this software. Now, what do they usually say? We already covered this in some of the previous talks. For each one of those categories, as far as detection, diagnosis, triage, there is a federal code that explains what needs to happen to get appropriate FDA clearance. And all this is easy to read on the internet. Each one of those codes has extensive explanations. In our case, for this class 2 devices, one of the key sentences here is that the device is not intended as a replacement for a complete clinician's review or their clinical judgment that takes into account other relevant information. It basically says that, yeah, here, we sold it to you, and we're going to highlight stuff for you, but don't use it as a replacement for radiologists. In the interest of time, I'll skip this one. Here's actual verbiage from a couple of different FDA-cleared AI algorithms. User is presented with notification. Notifications are meant for informational purposes only. It's not intended for diagnostic use beyond notification. Now, each one of you may have AI algorithms already installed, and it's fairly easy to go ahead and look it up and to see what it actually says, what this thing was cleared for. Now, if you know 510K number, that's really easy. You usually don't know that number. You can put a device name, that may be easier. There is a list of recently approved names on the same website through FDA, so if you Google it, you will usually be able to find exact wording that you need to plug into this search tool that FDA provides. So I whited out the actual name of the device that we are using, but guess what? The device does not alter the original medical image and is not intended to be used as a diagnosis device. So I think that pretty much answers my question as far as what I would do if AI shows me a fracture and I don't necessarily believe it. If I'm confident that it's showing me an artifact, I see absolutely nothing wrong with me saying there's no fracture over there and just leave it at that. Now, if I'm not confident, then I would do what I would normally do with complex cases. I would say, get some more imaging, get some follow-up, and perhaps I may say something about, yeah, I detected something, but it's uncertain because of this or that. But it's still up to you and me to decide, are we going to make a finding out of it? When you are evaluating software, think about how that software was created. Ask questions. A lot of this can be gleaned by just Googling and looking up this FDA clearances, because they do have studies as they get cleared, how many patients were involved, who were the ground truthers and so on. You may want to know how many years of experience ground truthers had. You may want to know what exactly they called fractures. Did they only look at acute fractures? Did they look at chronic fractures? And then look at their statistics. This is an excellent book from 1950s, I believe, that actually gives medical professionals a lot of credit. It butchers a lot of statistics that advertisers do when they sell toothpaste and things of that sort. And they say, think what would happen if doctors were doing it. So let's be honest. Let's not do what we see on television where claims are made to sell all kinds of products that have nothing to do with healthcare, and realize that every time we open an AI-produced image, it is based on a sample that may or may not apply to that particular patient. The final decision is up to us. I'm going to stop here in the interest of time, and I thank you very much.
Thank you. Any quick question? Okay, then I'll proceed to my talk, which is the last talk for this session. And for the other speakers, we have some questions from online chat, so we'll take them after this talk.